Hello, everyone that's coming in.
Oh, we just have, let's see, we have 4 now.
I'm with my co-host here. We're just waiting for people to join slowly. In just a few minutes, we'll get started. But I want to say thanks for everyone being here as you come in. This is our second webinar. It's entitled Harm Reduction, Reducing Stigma by Improving Health Outcomes. And my name is Steve Caldwell. I use he, they pronouns. I'm one of the SUNAR's regional peer leads, and I'll be chairing the meeting today with my little buddy here, Leaf. We'll just give people a couple more minutes to join. Is there baby entertainment? Will we just wait a couple more minutes? Yeah, good job saying hi. Well done. Yeah, you're in another Zoom meeting. This baby has been to at least 35 Zoom meetings, I'm sure. At least that from age 1. All right. I think we'll get started if everyone's all right with that. Just give me 1 sec here. So again, welcome to SUNAR's second webinar titled Hi. Okay. Sorry about that. There may be a couple baby screams now and then, but I'll do my best. So basically, welcome to SUNAR's second webinar titled Harm Reduction, Reducing Stigma by Improving Health Outcomes. My name is Steve Caldwell. I use he, they pronouns, and I'm one of SUNAR regional peer leads. Before we begin today, I have a few housekeeping items to discuss. This event is being recorded and will be shared on our personal website, on our SUNAR website and social media within a week. If you're having any technical difficulties, just try logging out and rejoining. And please use the chat function to introduce yourselves. A land acknowledgement based on where you're joining us from today and anything else you'd like us to know. If you have any questions or comments, like he does right now for the presenter, please put them in the Q&A box and we'll save them till the end so there's no interruption. We'll be providing a link to an anonymous survey in the chat after the presentation, and we would really appreciate your feedback so we can continue to improve and grow. If you'd like to learn more about SUNAR, please visit our website, sunar.ca, SUNAR.ca, or check out our Facebook. The page is Sun Atlantic Region, all one word. And Katie will be putting that into the chat too. Thank you, Katie. So next we're going to be doing our safer spaces and land acknowledgement. Just 1 second while I switch my screen. If you don't mind pulling that up for me, Katie. Thank you very much. So this is our virtual land acknowledgement. We do this before each meeting. SUNAR would like to acknowledge that we are all sitting on the unceded and traditional territories of Indigenous peoples. Together, Nova Scotia, PEI, New Brunswick, and Newfoundland are traditionally called Mi'kmaq. Our members in Nova Scotia and on PI are situated on the territory of the Mi'kmaq. In New Brunswick, we are sitting on the land of the Wolastoqey, otherwise known as the Maliseet or Mi'kmaq. We respectfully acknowledge Newfoundland, the Ukadahumaguk, sorry about the pronunciation there, in Mi'kmaq as the ancestral homelands of Mi'kmaq and Beothuk. We recognize the Inuit of Nunatsiavut and the Inuit of Nunatakavut and the Inuit of Nitassiv and their ancestors as the original people of Labrador. Please join me in a moment of reflection to acknowledge the harms and mistakes of the past and to consider how we may care for each other in our way to try to move forward in a spirit of reconciliation and collaboration. Thank you. This is our Safer Spaces statement that we take into all of our meetings as well. In this virtual space, we will treat each other with respect and dignity, regardless of age, race, gender expression, gender identity, sexual orientation, levels of ability, spiritual practices, and all other diverse identities. Everyone entering the space has a responsibility to uphold these values. SUNAR is committed to and encourages all those who gather with us to speak from personal experience and avoid speaking on behalf of others. Try to use I statements to share reactions or experiences such as I feel, I'm affected by. Don't make assumptions about others' identity or experiences. Listen to each other so we understand various perspectives. Share beliefs and opinions. Just one sec, sorry about that. Could you hang up the phone, please? Just, my apologies. Share beliefs, opinions, and points of view rather than judgments. Maintain confidentiality. Information shared here should stay here. Be mindful of pronouns of others and use them. It is okay to ask if you don't know. We're all here to grow, to connect, and share our experience, knowledge, and light in this space. Sorry about the phone call. The phone literally doesn't ring here all day. And of course, it goes off now. I really appreciate that. All right, so moving right along. So I want to tell you basically more about this organization who's hosting the webinar. So Direction 180 is who we work for and receives funds from Health Canada's Substance Use and Addictions program called SUOP. To create SUNAR basically is where we got that money. The Substance User Network of Atlantic Region started in August of 2020. The SUNAR project seeks to adapt a peer-led model based on the needs of people within lived and living experience of substance use in 8 communities across the Atlantic provinces: Truro, Sydney, and Halifax, St. John, Fredericton and Moncton, Charlottetown, PEI, and St. John's, Newfoundland. As SUNAR, we aim to unite, inform, and open a dialogue between people who use substances in Atlantic Canada. It also strives to increase engagement between people who use substances and service providers and policymakers to decrease substance use-related stigma and isolation, and increase evidence-informed policies, programs, and practices. Ultimately, SUNAR works to enhance and save the lives of people who use or use substances. And as a person with lived and living experience, like I'm literally living proof. I call up many of these people from SUNAR and they hold everything inside of me in their hands, and they offer a harm reduction that I have not experienced. So I'm legitimately proud to work for this company or this organization. So basically SUNAR has some key partners. With the help of key partner harm reduction organizations through Atlantic Canada, SUNAR engages with a network of approximately 40 people with living and lived experiences using substances to participate in knowledge exchange, skill-based workshops, and other capacity enhancing activities. And like I said, these people have started out as people on the screen, they've become allies and then forged fellowships and become friends too. So it's really a monumental shift basically in my life personally. We have a monthly newsletter that I'm lucky enough to be involved in writing, and other people are involved in too. So SUNAR also creates these opportunities for people to share their lives and share in these unique spaces and create opportunities from creativity that they know and inside them have learned on the path. Anyone can sign up to receive our monthly newsletter, which is a collection of harm reduction and substance use related resources in Canada with a specific focus on Atlantic provinces. And Katie will put a link there. But also, like I mentioned, I think one of the strong parts of it all too is there's education, but it's also matched with agency and giving people a space to create. The bottom part has a really amazing part on poetry and artwork and interviews. And basically also we'd like to introduce Emily, the subject and the person who has come before us to share their integral information that helps people along the way. So I'll introduce Emily here quickly, but I'm sure it won't capture all of their greatness. I've already had really amazing harm reduction moments with Emily, and people who are just there for you and meet you where you're at are pretty wicked people. So Emily Beaudeschamps graduated from the NBCC MLT program in 1997 and completed her Bachelor of Applied Science from Charles Sturt University in 2004. I almost said strut, apologies. She has worked for Horizon for 21 years, 10 years as a manager, most recently in chemistry and toxicology lab at St. John Regional Hospital until moving into the director role January 2022. I think you work with some of my friends, Tanya Celeste. Emily represented Atlantic Canada on the board of directors of the advocacy of Moms Stop the Harm and facilitates a peer-led Holding Hope support group for families with a loved or loved ones currently struggling with substance use or working on recovery. And I would fully endorse those organizations, and I'm seeking some help from them currently. So yeah, that's Emily, if you want to take it from here.
Okay, thank you, Steve. I'm just going to see if I can share my screen. Sorry, guys, I'm not the most technologically advanced person that there is. Okay, is my screen showing?
Okay. Yeah, screen's there.
Okay, thank you. So thank you, Steve, for that introduction. And I want to thank SUNAR for having me here today. I really appreciate the opportunity to speak about harm reduction and the stigma associated with substance use disorder, and to share some of my personal story, and also from the perspective of a healthcare worker. So as Steve mentioned, I am on the board of directors for Moms Stop the Harm, representing the Atlantic region. And I'm also, in my professional side, I'm the administrative director of the laboratories for Horizon Health Network in the St. John area. And my past experience included, as Steve mentioned, I used to oversee the forensic toxicology service in New Brunswick. And also I spent a lot of years working in phlebotomy. And so I have direct patient care experience as well. So just an overview of my presentation. I'm going to talk about Moms Stop the Harm and tell a little bit about my story, and then look at why do we have a drug poisoning crisis, the role of harm reduction, the role of drug policy, decriminalization, and safe supply, and then we'll talk about reducing stigma in healthcare, what we have going on at the St. John Regional Hospital lab, and then we'll have a little bit of time, hopefully, at the end for questions. So I just need to, okay. So Moms Stop the Harm advocates for a safer regulated supply, for decriminalization of people who use drugs, for harm reduction in all provinces, evidence-based treatment, upstream prevention, and meaningful inclusion of people with lived and living experience and their families in all decisions that affect them. And so this slide comes from Petra Schultz, who was one of the co-founders of this organization. And basically the organization started when Petra and a couple of other moms in BC and Alberta lost their children to accidental drug poisoning. And they got together, they started this advocacy group, and we now have more than 3,000 members nationwide. And these are some pictures of some of the demonstrations that they've held before I joined. So this is a collage of some of the people that our families have lost to this crisis. And one of the biggest messages that we like to try to get across to people is that substance use and overdose can affect anyone, and overdose does not discriminate. So challenges faced by our families. This is a photo of a rally in Victoria from 2018. And for anybody who's friends of Mom Stop the Harm, you may recognize some familiar faces here. But basically our families face a lot of challenges. We're navigating a fragmented system for treatment for mental health and addiction. There's social isolation, isolation because of the stigma associated. So a lot of people, I had a mom last week telling me that she has no one to talk to because her friends don't understand. And so people are really isolated. And then they're caring for their loved ones. And a lot of people, a lot of the loved ones, they need a lot of care and they need a lot of support. And it's not only emotionally taxing on the families, but there's also an economic strain. So if the loved one is not able to work, or if they have their own children that need support, that puts a burden on families as well. And then coping with their grief and their own ongoing trauma. And so we end up, with our own personal, physical, and mental health concerns because of the stress associated with supporting our loved ones. And so this is one of the reasons why we started our Holding Hope groups, is to provide support for families. So this is my son, Albert. He's now 28. In the picture on the left was when he was 17, and he's in India. We went to visit a family in southern India, and he had an absolutely fabulous time. The picture on the right is his grade 8 graduation, where he's holding his baby sister. So Albert was always a very unique child. He told us when he was 8 years old that he wanted to be a hobo when he grew up. And, we laughed at that. We said, what do you mean you want to be a hobo when you grow up? And he just wanted the freedom of living the life that he wanted to live, traveling the way he wanted to travel, and seeing the world from his own eyes and from his own perspective. He also is very musical. He started out playing the violin when he was a really young child. And then he went on to play guitar. He plays drums. He plays anything that he can pick up. He's musically gifted. And then he really struggled when he got to high school, and he started experimenting with drugs. He didn't really fit in with the crowd because he's always kind of marched to his own tune. And so he graduated from high school, and then he made the choice to move away from home and try to see the world a little bit. And he ended up using drugs and living on the street for several years. He lived in Calgary, Edmonton, Vancouver, Victoria. He met a lot of people, and he used a lot of drugs. And so it was really difficult for us as a family, knowing that he was living in Alberta, and he would call us and tell us how wonderful his life was. But we didn't have a lot of contact with them and didn't have a lot of, insight really into how he really was doing. And I remember when he called me and told me that he used crystal meth for the first time. And he told me that it was, suddenly everything seemed clear to him, and he understood what life was supposed to be and what he was supposed to be doing. And he felt like he was really on the right path to where he was supposed to be going. And it was devastating for me as his mom, because of I was terrified. I was, so scared of where is my kid going to end up. And I didn't really know what to do. And so I just, my biggest action in that time was just to try to keep the connection open and try to keep our relationship. And so I would just go to see him wherever he was and sit with him on the street. And, I'll talk a little bit later about some of the things that I learned while I sat on the street with him. But essentially, it's what led me into where I am now. So what happened with Albert while he was living on the street and he was injecting, multiple times a day, he started having some pain in his back, and he went to the emergency room in Calgary and he was turned away. They said, go away, you're, just looking for drugs, go somewhere else. And he was very much dismissed. And so then he went back a little bit later because the pain was getting worse. And they tried to draw some blood work. They were not very compassionate with him when they were attempting to get his blood. And he was really sensitive because, because he was using his veins all the time. And they kind of dismissed his knowledge of his own veins. And so he ended up not having any blood work drawn the second time either. They wouldn't give him anything for the pain and said, you're just looking for drugs. Drug-seeking behavior is a term we like to use in healthcare, which is, highly stigmatized. And so the interesting part that he told me later was, I can get way better drugs on the street than what they're going to give me in the emergency room. So the thought of, just the term drug-seeking behavior is ludicrous to me. So what ended up happening was he lost, his legs gave out. He had an abscess, Staph aureus infection growing on his spine, and he was paralyzed from the waist down. And so this is a picture of his incision after his surgery. And he had 43 staples running down the back of his spine, and he was on IV antibiotics. And then he had to rehabilitate, and he basically had to learn how to walk again. And so this was in 2016, and his experience in the hospital was eye-opening for me as a healthcare worker, because I could see that he wasn't getting the best possible treatment that somebody else might get, and we'll get into that a little bit later as well. So one of the biggest things for me was that relationship became so important here, because my advocacy on his behalf really saved his life. He wasn't able to walk. They were going to discharge him to the street. And I'm really, really fortunate that I work in healthcare, and I was able to get him transferred to my hospital in St. John so that he could continue his treatment, because somebody who can't walk, being discharged to the street in a wheelchair in December, it's a recipe for disaster when he has no support network there. So I want to talk a little bit about the drug poisoning crisis. So in Canada right now, or in 2021, 21 Canadians died every single day on average. We had this information comes from the Government of Canada website. So there were 29,000, apparent opioid toxicity deaths between January 2016 and December 2021. 7,500 apparent toxicity deaths during the time period of 2021, which equals 21 a day. The majority of the deaths happened in British Columbia, Alberta, and Ontario, but increases were seen in other regions. And most of the deaths involved males and individuals between the ages of 20 to 59 years. We saw a 96% increase in the first year of the pandemic. And the numbers are there, 3,700 the year before the pandemic, and then 7,300 the first year of the pandemic. And fentanyl and fentanyl analogs continue to be the major drivers of the crisis at 86%. And often, most of the apparent toxicity deaths involve a non-pharmaceutical opioid. And so when you look at the data year over year, compared to 2016, where there were an average of 7 Canadians dying every day, to 2021, where we had 21 Canadians dying every day. And so this is an interactive map that you can see on the Government of Canada website, which is, you can hover over the province. The data is not great. I mean, it's good, but it's not perfect. We have Manitoba doesn't report. and or doesn't report it on the same timeline, I guess, as the other provinces. And then we also have some provinces that report on stimulant-related deaths as well, and so those numbers are kind of in the mix. But overall, you can see that it was 7,500, and I've highlighted Nova Scotia on this slide, and you can see what the trend has been over year over year. And so this is just the reason the top part is here is because I think it's important to point out that the Government of Canada recognizes that the toxicity of the supply continues to be a major driver of the crisis. Yet, when we talk about safe supply, they really drag their feet, they really drag their heels on making widespread changes to the drug policy. And then I included a little bit about the polysubstance nature of the overdose crisis. And, you know, it's important to note that there's often multiple substances involved, including stimulants, and you can't really add the numbers together because they're often concurrent. And so one thing I found this last time when I went on to the website, they're now including drug poisoning hospitalizations, which I think is really important because in addition to the 29,000 deaths in the last 5 years, we also had 30,000 opioid-related and 13,000 stimulant-related poisoning hospitalizations during that time frame. And then this was the 2021 data, so about 17 patients a day being admitted to hospital for opioid-related hospitalizations, yes. And then 2,300 stimulant-related hospitalizations, which, as I said, you can't really add those together, but it gives you an idea of the number of people being admitted to hospital. And more than 41,000 EMS responses to suspected opiate-related overdoses in 2021. We saw a 27% increase in the first year of the pandemic of hospitalizations, and the median length of stay is 3 days. And the reason I included this data is just to highlight how much of our healthcare dollars is being spent on the drug poisoning crisis. 41,000 EMS responses because of the toxic drug supply. And data, of course, doesn't include hospitalizations for other drug-related harms, such as drug-related or substance use-related infections, such as endocarditis and, like my son, his abscess and his paralysis. And so these are just the numbers year over year of the hospitalizations per day. And so in 2021, the number would be somewhere between 17 and 24 hospitalizations every day. So how did we get here? A lot of people struggle with personal trauma and mental health, and our mental health system, when they, back 50 years ago, we had mental hospitals where people could go to, and we moved away from that and integrated mental health into health, but we didn't integrate it very well. And so people struggle with mental health, and it's increasing because of the increased social pressures and a lot of other social factors, and then personal trauma. And so people are struggling more today than they ever have. And then there's stigma and discrimination against people who use drugs. There's poverty is a major driver of the crisis, and the lack of affordable housing, and a lot of that has to do with the more people live in poverty and the longer they live in poverty, the more stress is placed on them because of the insecurity. And then, of course, racism and decolonization of Indigenous peoples. And, I have an example of that in my own family. My grandmother was a member of the Wolastoqey First Nation in Woodstock, New Brunswick. And when she was a young woman, her sister was murdered, and her sister and her white boyfriend were murdered together, and it wasn't investigated. It was deemed a murder-suicide, even though there was very clear evidence that it was racially motivated. And so she feared for her life. And then when she married my grandfather, who was white, she lost her Indian status, and so she was isolated from her community, and she turned to substances. And so her trauma turned her to substance use, and then passed on to my mother and her family. And so, you know, and it passes on down the line. So racism plays a huge factor. We also know that, you know, people of color and Indigenous people are misrepresented in the prison system by much higher proportions, and they're misrepresented in substance use as well, in higher proportions than any other group. There's a lack of health services and a lack of access for people who need help with substance use. And then, of course, the war on drugs. So prohibition has increased the toxicity of the drug supply. It's driven the creation of fentanyl analogs and the designer benzos that we're seeing now that are killing people. And then, of course, there's the role of big pharma. And we all know about OxyContin and the crisis that was intentionally created by the really shoddy practices, the marketing practices of Purdue Pharma. And if anybody here has not watched Dope Sick, I highly encourage you to watch it because it's horrifying the way that company marketed their product. And today it's causing fear among providers to prescribe pain medication to people with substance use disorder, for fear of being labeled as an overprescriber, and it's causing people to not be able to get treated when they need it. And so then we had COVID-19, and you know, it really increased the number of deaths in a lot of ways, because people were more isolated because of the public health measures to contain the spread of COVID-19. It disrupted the supply routes. So whenever the supply routes disrupted, then the street supply becomes increasingly toxic. And people continued to be criminalized. There was a lack of access to safe supply, which is, you know, safe pharmaceutical alternatives in this context. And so the government responded, and they did allow exemptions for safer prescribing. And I know that, you know, there were some fabulous efforts in Nova Scotia by some prescribers there to really save people from this particular portion of the crisis. So when we're talking about harm reductions, relationships are really key. And so harm reduction provides needle exchange and sterile supplies, supervised consumption sites, naloxone distribution, and drug safety education, because relationships are key. Meeting people where they are at is key. And I found that myself through my experience with my son. I remember, you know, visiting him on the street and hanging out with all of his friends. And we got kicked out of Tim Hortons, and we got kicked out of, you know, we were sitting on a picnic table, and we were made to leave from there. And they actually told me, you know, they pointed at me and said, "You can stay, but they have to go." And I remember I went to Subway one day, and I bought a bunch of cookies, and I took them and I gave them to his friends. And one of his friends said to me, "You're a really cool mom." And I was like, "Ooh, what do you mean? Like, is that a good thing or a bad thing?" And she said, "My mom would never come and buy me cookies and sit on the street with me." And at the time, you know, I really wasn't sure if I was doing the right thing or not. And in hindsight, I know that relationship was so important when it came to Albert needing help. And so there's a myth that among the general population that harm reduction condones drug use, when the fact is it just accepts the reality that the person is living in at the time. And, you know, who are we to judge what somebody does or doesn't do? Dead people do not recover. And I repeat this a few times in my presentation. If we allow people to die, there is no chance of recovery. So this is one of Petra's slides again, And this is in relation to our youth. It's really important that we educate people, especially our young people, because knowledge is power. And my children are very well educated on substance use and what harms could be associated with that. They know that if they are ever going to try substances, that they need to try them in less harmful ways, so that they've seen firsthand what their brother went through with the harms associated with his use. And I think it's important to, we've always been told, well, just say no, just don't use drugs. Everybody, has been through the DARE program where we don't do it. But we all know that is ineffective. And abstinence isn't everybody's goal, and it shouldn't be everybody's goal, because abstinence doesn't work for everybody. And that's something that's really, really important for people to recognize. So I tried to find an updated article. This article is from this past April, but I couldn't find one that was really this good. So Fredericton police boast their biggest drug bust in the force's history. And this quote was from the article. "It's safe to say today that I guarantee this amount of product would result in overdoses, increase in crime, and even death." And I agree with their statement. That this amount of product would definitely, could definitely result in people dying and in crime. But what their statement implies is that they're reducing overdoses and reducing crime by taking this product off the street. And that's simply not true. There's more where this came from, and it will likely be more toxic. And the people that went to jail or are on trial for this arrest, there's people to replace them. And there's probably some turf war that happened as a result of this drug bust. So it actually increased the amount of crime that might have happened otherwise. Drug seizures don't save lives. They actually make the supply more deadly. And that's because this supply has been taken off the market, but the demand is still there. And so the supply that comes in to replace it is going to be cut with further toxic substances. The war on drugs is a war on people, and we need to end prohibition because it's killing our loved ones. And then in light of this, the New Brunswick government announced $3.3 million in addition to their already healthy budget for drug enforcement. And this does nothing to address the problem. And if we look at that extra $3.3 million, plus all of the thousands of dollars that we already spend in healthcare costs, we really could have a robust program for people who use drugs. Supportive program. So I just want to talk a little bit, I'm going to talk about this later, but just a little bit about other behavior-related health conditions that aren't criminalized. So we have type 2 diabetes, we have obesity, lung cancer, knee and hip problems, and sports injuries. They're all related to behavior, but the only one that you can get arrested for is substance use disorder. And every other health condition, care increases when the patient doesn't respond to treatment. But in substance use disorder, care decreases, and I'll show you that a little bit later. So Mom Stop the Harm calls for the decriminalization of people who use drugs. And as you can see in this infographic here, there's a lot of resources are put into criminalizing people. And criminalization causes people to hide their use, which in turn causes people to die. So we could divert resources to supporting people rather than punishing them. And a recent poll showed that the majority of Canadians support decriminalization of drugs. But there are the minority who the politicians, the other 40% in opposition, the politicians seem to be supporting the traditional approach. So examples of decriminalization include harm reduction supplies. Somebody can go to Avenue B and pick up some supplies without fear of being arrested. And then another example, and we had a Mom Stop the Harm member who was involved in putting this in place, is that if you're with your friend and you're using and your friend overdoses, then you can call an ambulance without fear of being arrested. And there are some caveats added to that, but the mom who advocated for this, her son died and his friends were afraid to call for help. Otherwise, he might still be here today. So one of the actions that Mom Stop the Harm did this year on Bereaved Mother's Day, which is May 1st, is the Sunday before Mother's Day, we sent 1,000 packages of poppy seeds to the Prime Minister's office. And we sent them from all across the country. Every province was represented in this action. And so we basically wanted to show the Prime Minister, this is how easy it would be to provide safe supply. We grow poppies and we make our own. And you know, that might be a little bit of a dream, but we basically we're trying to make the point that, you know, it's time to implement some evidence-based policies on safe supply. And some of the other things that we included is reducing some barriers to getting exemptions to the Controlled Drugs and Substances Act, reducing barriers to funding mechanisms so that we can actually you know, implement urgent changes quickly as they're needed, rather than going through all the red tape. And then we also included in that, you know, using a range of safe supply approaches, which include, you know, peer-led models, public health models, and prescriber models, because not every model, or, you know, each of those models is not a one-size-fits-all, and they don't necessarily work for every person. And then also ensuring equitable access, because we have, you know, people with substance use disorder are traditionally underserved in our healthcare system. And so some of our actions for International Overdose Awareness Day, which a lot of people prefer to call now Toxic Drug Poisoning Day. We have some actions that we're doing. So wearing and distributing purple ribbons, tying purple ribbons to trees, organizing or participating in an IOD event, and we're having a harm reduction fair in St. John next Wednesday. So if anybody's in St. John, please come out to King Square between 10 and 2. And I have to thank our partners at Avenue B for helping us organize that. It's really great. And then the Purple Chair campaign. And so that signifies somebody who's no longer at the table. And it's purple to, because that purple is the color that we traditionally recognize to be associated with Overdose Awareness Day. And then the fourth action is demonstrating what a regulated safe supply could look like. And so the Drug User Liberation Front, DULF, which is in BC, they will purchase drugs. They advocate for purchasing drugs in bulk, testing them, and then packaging them. And they do this as a demonstration for this is how easy it would be to provide a safe supply. And so last year, on August the 31st, we actually had some moms who went downtown Vancouver as a demonstration, and they passed out these drugs and said, you know, you can take this drug, you know exactly how much is there, you know exactly what's in it, and this is what safe supply can look like. So I want to talk about stigma and how we can address stigma so that our healthcare system can be all inclusive of all people. And so one of the major drivers of this stigma is the belief that substance use is a moral failure, that it's not a real illness, that people are to blame for their own condition, and that they could stop. They could choose to stop. It's their choices that have brought them here. And then we stereotype them as being dangerous, and which doesn't help. And so people are afraid of people who use substances because they think that they're criminals and unpredictable and a threat to other people. Excuse me. So then the stigma associated with substance use intersects with other drivers of stigma, such as racism, gender identity, and ageism. And so if you have somebody who uses substances and then they're Indigenous, then their stigma is increased. And then when they also have a stigma, a health-related condition that's stigmatized, such as a mental illness, then that stigma is compounded again. And so what happens in society, we have negative portrayals on the media, we have social exclusion, and everybody has seen all the headlines recently about the tent cities that, or the tent communities that cities are trying to, get rid of. And the residents of the areas, they argue that it's not safe. And, they're arguing that it's not safe for them because, the tent cities are in close proximity to their homes, and the people are criminals because of their substance use. But because they're criminals, that means they're going to steal from me and they're going to break into my home, and I'm not safe to walk through the park. When the reality is, who's actually not safe, because we have people living in tents that don't have access to clean drinking water, and they don't have access to sewage treatment. So where is the actual the safety concern with this community? And so there's discrimination in housing. And then there's the failure to accommodate employees with substance use disorders. We still have employers that are doing random urine drug tests, and that should have no bearing on their performance as an employee. If their substance use is affecting their employment, that's a different story. But if it's not, if there's no effect, why are we testing people for drugs? Why are we testing them for what they're doing on their own time? Or even, and I sorry, I don't mean that to sound the way it did, because people can work and use substances. People do it all the time. People take prescription drugs when they're at work. It's something that is very, very much stigmatized. So then the stigma practices of the healthcare system, there's demeaning language. We say things like my son heard, which is drug-seeking behavior. People are called frequent flyers. And then there's reduced empathy from healthcare professionals. I've had paramedics say to me, I gave them naloxone, and they weren't even grateful that I saved their life. And I don't know of any healthcare worker that expects gratitude from their patients. It's nice when you hear gratitude, but is that really why we're doing this? Are we really here because we need to be thanked? And then that lack of empathy of putting themselves in that person's shoes, where they go from a euphoric state where they fall asleep and they're in no pain, to they're suddenly in opiate withdrawal after they have the naloxone. So of course the reaction is violent, and that paramedic or emergency professional should be grateful that they're not in that position, rather than expecting gratitude from the patient. There's less motivation to meet the needs of people who use substances because of that lack of empathy. And then there's a lack of training in harm reduction. And one thing that I learned is that not every hospital has the same harm reduction policies and practices. And even within the same hospital, not every unit has that ability to meet people where they're at. And so then what happens for the experience of people is, coming into the healthcare system, they already feel stigmatized, and they already feel shame and embarrassment, and they're getting stigma and shame from their families and their friends. And so it prevents people from accessing treatment. So they won't come in because they know how they're going to be treated. And so it decreases their use of health and social services, and makes them hide their disorder, and then causes them to lose their employment. And they're at increased risk of homelessness. And so then they resort to health harming coping strategies, and which leads to increase in poor physical health, quality of life, and poor psychological outcomes. So what can we do about this? And so this discussion group that put together the report that was referenced in the previous slide, this is a quote that came out of that report. And so they said, in order to address that root cause of stigma, we need everybody to hold that mirror up and ask themselves that really important question of, how am I implicated in these systems? What am I doing to contribute to this problem? Because, we have our policies in place. We don't stigmatize people. We treat people the way we want to be treated. We treat them like our family. We be empathetic. But how many of us have held that mirror up and said, okay, what am I doing to contribute to the problem? And I found that that's what happened to me when I went to visit my son on the street, and I was sitting with him, and I was, I will admit I was embarrassed to be sitting with him on the street, because I thought, how am I here? How is this my kid? I love him so much, and I see him for the wonderful person that he is, and he's here living on the street and using drugs. And what am I doing here? And I watched people walk by, and the looks on their faces when they looked at him was even more shameful to me, because I recognized my own feeling in their faces. And I said to myself, I have to change, because I'm looking at people like they're looking at people, and that needs to change. And, so holding that mirror up is challenging, but it's really, really important. And it's not just for substance use disorder, but, we found that there was a big movement when, when the Black Lives Matter movement was revived in the States early in the pandemic. We found people examining their own internal biases for racism, and how can I change so that I'm no longer contributing to the problem? So what do we do about this? So work on your own thought processes and challenge your filters, because biases can be unlearned, and you can monitor your own thoughts. And another example of this is in our society. I'll pick on myself again. When I was 22 years old, I had a work colleague come up to me and say, "Can I ask how old you are? Because your face looks really young, but I noticed that you have a lot of gray hair." And so in that moment, I was like, oh my gosh, I do have a lot of gray hair, but I didn't realize everybody else could see it. And so from that moment forward, and for the next 25 years, I colored my hair. And I spent a ton of money that I would love to have back on coloring my hair. And it wasn't until just this year that I thought, you know what, I don't want to feel like I look older because I have gray hair. And so I started working on that with me, and I looked at pictures of people, and I looked at other people with gray hair, and I started really noticing, it doesn't actually age people. We have this idea that gray hair ages people. And when I let my hair go gray, I don't feel like I look older than 47. And I don't feel any older than 47, and I don't feel like I look any older than 47. So it took a bit of a process for me to get here, but my bias that gray hair ages me, really, I could unlearn that. And it was easy to do, difficult to do, but easy to do. The second thing is to bring your awareness to your organization and critically examine the organizational culture. So what's happening in your workplace? And I'm specifically talking about healthcare here. What's happening in your hospital with your coworkers, in your clinic, that is causing or compounding the stigma associated with substance use. And then it's an ongoing commitment. So, just because I had that light bulb moment on the street with my son, that I need to change the way that I feel, or I need to change the way that I think and the way that I see people, it doesn't mean that happened overnight. And it's been a continual challenge for me, and it's a lifelong commitment. So this document is on it's published by the Public Health Agency of Canada, and it's about reducing substance use stigma in the Canadian health system. And for any healthcare workers, if you haven't already looked at this document, I would really encourage you to, because there was too much here for me to really go into, but it's a great document for reducing stigma that is embedded into our system. And it really comes from the individual, and we have to educate our peers and our colleagues to make sure that we're treating people fairly. And so the role of language in reducing stigma, there's two really simple principles. use neutral, medically accurate terminology when you're describing substance use. And the second one is to use people first language that focuses first on the individuals and not on the action. And, you know, a lot of times I've found that I have to be forgiving of people because, again, the change doesn't happen overnight. It is a commitment. And, you know, people in my Holding Hope support group, they use terms like addict and they use terms like drug abuse, but they're trying. And that's, you know, I think it's important to be kind to people to you know, to understand that it does take a little bit of time to shift that. And we're here to be kind to everyone but to guide them on that path to the more inclusive language. So I wanted to just basically talk about those conditions that I had touched on earlier, and then what the perception of them is and the bias that might exist, and then what happens with that condition as they get worse or there's a poor response to treatment. We've all seen on people's Facebook when their child breaks their leg because they're playing hockey, or, you know, they get a concussion, or they need knee surgery because they have a torn meniscus from playing sports. Because sports is perceived as a healthy behavior, we encourage this and we glamorize it. And, you know, we praise our kids and we say, oh, she's out for this season, but she's going to be right back at it next year. And, you know, we're putting our kids in these really dangerous, physically demanding situations that they love doing. And you know, we increase we give them unlimited numbers of surgeries and rehabilitation and medication because we see it as these guys are heroes, you know, even though their behavior is what's causing their illness or their injury. There's no stigma associated with that whatsoever. Knee and hip replacements, it's accepted as a normal part of aging. It's often related to obesity or athletes, but care always still increases as the condition worsens. Type 2 diabetes, even though this disease is preventable, it is related to behavior such as diet and lifestyle. It's not stigmatized. And we increase care despite non-compliance. So as the patient is non-compliant, I have a family member who he was non-compliant his whole life. His medication increased, his care increased to the point where he was on insulin. And then he was at the point where, you know, he didn't lose his vision, he didn't need dialysis, but he just finally decided, you know, I actually need to make some lifestyle changes. But he lived with type 2 diabetes for probably 30 years before he made any changes, but his care continued to increase. And, you know, to the point of kidney transplants, people could, you know, we will take them all the way and always be supportive of their condition. Lung cancer and emphysema, it's stigmatized even in non-smokers. My mother-in-law had lung cancer. She never smoked a day in her life, and people didn't believe her. They would say, no, you must have smoked at some point. So it is heavily stigmatized, but we still provide care. We still increase care when there is a poor response, even to the point of we support smoking cessation programs. And if the patient isn't interested in stopping smoking, we will provide them with you know, a safer alternative while they're in the hospital. We'll give them nicotine patches. We will give them you know, nicotine gum, just so that they don't go into withdrawal while they're in the hospital. Obesity is highly stigmatized, but again, not criminalized, and care usually increases, although I'm sure that we've all heard stories of people going to their doctor and saying, I have pain in my back, or my knees are really sore, or, you know, my back hurts and I think I need a breast reduction. And the doctor's response is, I want you to go and lose weight and then come back and I'll treat you, because their justification for that is, I'm going to treat the whole patient, when, you know, the reality of that argument is they're actually not treating the patient at all if they're refusing to treat them until they lose weight. And then substance use disorder is the highest of the stigmatized health conditions that are related to behavior. There's a lack of trust between the patient and the care provider, which leads to the patient not feeling safe to be upfront with the care provider, and also because their condition is criminalized. And so care decreases. So we use punitive abstinence-based treatment programs where, if I'll talk in a bit about the limitations of drug testing that we use, and how that, sometimes people can be removed from treatment programs based on faulty testing, which is really heartbreaking. And so there are a lot of barriers to accessing treatment because regardless of why somebody presents to the emergency department, people usually just want to treat the addiction. So they'll say, well, I get that you're here because I'll use the example of a mom who her son passed away this summer. He struggled with opiate use as a teenager. He went on methadone, and then he didn't want to be on methadone anymore. He didn't like it. He didn't think it was for him. So he tried to talk his care provider into switching him to Suboxone, and they didn't think that would be a good fit for him. So he didn't have the ability to do that. So he tapered himself off of methadone against his physician's advice, and he was substance free. And then he was in an accident where a car ran over his foot. And so this is to the last point of poor access to pain medication, even when it's necessary. He went to the emergency room, and because of his history, they wouldn't give him any pain medication. So here he is with a crushed foot. He's awaiting surgery, and they gave him nothing. And so he bought fentanyl on the street because he needed relief for that injury. And they ended up gave him pain medication for the surgery, but that was it, not for the recovery, not for any of it. And then he ended up dying from the street fentanyl that he was using. Okay, so I do have a short video, and Katie, I'm just gonna thank you. Katie, I can't hear the presentation or the video.
Sorry, I don't know why.
Oh, I could hear it then.
Oh, because I'm muted. Haha.
Yeah.
Okay. Sorry, folks. We'll try again. There we go.
Let's do a thought experiment. Imagine you're living with opioid use disorder, also known as opioid addiction. This condition can affect anyone and can have devastating consequences. But you've sought help. Methadone is one part of your treatment. With the help of this medication, support, and a lot of hard work, you've had a more stable life for almost 2 years. But you're still stuck with the stigma. This creates major challenges, including when you need treatment for acute pain. Now, imagine you've fractured your arm. You're treated in the ER, but you're in a lot of pain, so the doctor says they can prescribe something to help. You know it's relevant, so you mention the methadone. Prescribing an opioid pain medication is routine for this injury, but now you get the sense they don't trust you.
You'll have to see your methadone provider.
You get 1 dose of pain medication, and you go home in pain and feeling rejected. You wish you'd never mentioned the methadone. At the methadone clinic, the doctor tells you they only handle methadone, and that you should see your primary care provider instead. You can't get an appointment with your primary care provider before next week, but you're in pain now. So you try a walk-in clinic. This time, you don't mention the methadone, and you're prescribed a short course of a low-dose opioid. At the drugstore, the pharmacist reviews your file. They speak to you sternly about mixing medications. You're discouraged, but hopeful your primary care provider can help. But before you can see them, you're asked to do a drug test.
Difficult.
Your primary care provider reluctantly gives you yet another short prescription for a low-dose opioid. They tell you it's actually your methadone provider who needs to handle this, and that maybe they should increase your dose. Now, exhausted by the runaround, frustrated by the way you've been made to feel, and overwhelmed by your ongoing pain, you feel you're out of options. So how do you cope? You resort to something you thought you'd left in your past. You contact a drug dealer. You know this might be dangerous for you, but it's convenient and available, and you trust your dealer. You finally get some pain relief, but now you're ashamed and fearful of losing all your progress. Now, let's imagine this scenario again, but this time, the providers you meet are aware of stigma, and systematic changes have been made to reduce its impact on the care you receive. When you mention you take methadone, instead of reacting with suspicion and discomfort, your providers ask you some important questions.
How long have you been taking methadone at this dose?
Instead of making quick assumptions, they see a more complex picture. They tell you your pain should be treated aggressively and with close follow-up. When did you last use other opioids? They understand you may require higher doses of opioids to effectively treat your pain. They explain that for some people with substance use disorders, the brain perceives pain differently.
How do you feel about treating your pain with an additional opioid?
Your providers know that just increasing the dose of your methadone is unlikely to be effective. How is this plan working for you? They understand that the distress of untreated acute pain increases the risk of returning to old coping strategies. Now that you're fully informed, you and your providers work out a treatment plan together. This plan is not simple, but with the support of your care team, your treatment is successful. The opioid pain medication is tapered off as your pain subsides, and you continue with your regular methadone dose. Imagine how you feel now. Stigma shames and discredits people with opioid use disorder and creates healthcare systems that dismiss and disconnect people from care. To change this, individuals must examine their biases, and systems rooted in stigma must be reformed. Only then can people with opioid use disorder get the compassionate, evidence-based care they deserve. We can move beyond stigma.
I think you might be muted there, Emily.
Sorry.
You're good. I had a phone go off. It's all right.
Okay. Thanks, Katie, for supporting me in that, because I oh, what's going on here? Okay, here we go. So because I come from the lab, I give this talk to lab professionals about seeing patients and how we can change our language. And I see that somebody put, I was going through the chat when I was, while we were watching the video, and I saw that someone had spoken about the term substance use disorder. And I would be happy to talk about that afterwards, because, you know, if I'm using terms that are outdated and stigmatizing, you know, please tell me, because, you know, it's again, back to that internal bias. And, you know, I mean, it's a medically recognized term, but, you know, we do need to change some of the things that some of the words that we're using. So thank you for that. So one thing I always tell people is that venous access can be difficult because people who use substances intravenously, they will often have a lot of scar tissue. And so to recognize that it, you know, there could be trouble accessing that vein, recognizing that people have trauma. You know, I recall as a young technologist, I was trying to draw blood on a girl who she was in recovery but very newly in recovery. And she had a lot of trauma from her substance use, and she did not want her blood taken. And, so recognizing that people are traumatized from, and, and also, just listening to people, and empathizing with what they're saying, and using non-stigmatizing language when talking to people. And then, when we're looking at lab tests, treatment should not be conditional. And there's a limitation to the immunoassay tests that we currently do in New Brunswick, because we do not have access right now to a mass spectrometer to have targeted drug screening testing. That we send our tests out to Ontario, and it's a 7 to 10 day turnaround time. So what we do provide is a screening test, but there's a lot of, like I said, limitations to that. There's false positives, false negatives. And although those tests might be beneficial in an emergency room setting, they're not necessarily beneficial for treatment monitoring, just because of those limitations. And so mass spectrometry is the gold standard for drug testing. So what have we done about that at the St. John Regional Hospital? So last year, we participated in a competition called the Lion's Den, and it was to acquire funding to get a mass spectrometer in the province. And the idea of the Lion's Den, it's similar to the Dragon's Den that you see on TV or Shark Tank, where you have an innovative idea and you compete on stage in front of donors for $500,000. And so because of the pandemic, we couldn't compete on stage. So they did it more like a reality TV show, which was actually a lot of fun to participate in. We didn't win because they didn't see drug testing equipment as innovative. They saw it as standard of care. And so we didn't win for that reason. But you can see here, we actually ended up getting all the funding in just a few short months because we had such community support from the exposure that we had. So there was me on the team, and then in the middle of Dr. Jennifer Shea, who's the clinical biochemist at the St. John Regional Hospital. And then on the left is Dr. Duncan Webster. He's an infectious disease specialist in St. John. Many of you may know him. And so our next steps, because now that we have the funding, we are going to acquire the equipment. We'll perform our validations. We've created a toxicology network, which is comprised of infectious disease, pharmacy, the coroner. We have a member from RECAP on our team, and then the toxicology group from the lab. And so our goals for that network is to provide more meaningful access to the data, and be able to get that information pushed out to the community faster than what is currently happening. And so right now we're only getting that information based on the coroner's data, which is, could be months after the person has passed away. And so, having that data, access to that data faster is, hopefully going to help people to stay alive. And then we eventually want to move into drug checking because, right now we don't have a drug checking program in New Brunswick. Aside from, I know that there are test strips, and there's a little device that they have at Ensemble in Moncton, but we don't have the mass spectrometry, sorry, it's a really difficult word to say. We don't have that high level of accuracy available in the province. And so the bottom line is we have to keep people who use healthy and alive. And as long as the person is with us, there is hope. Dead people don't recover. And so this is Albert. After his recovery, he was walking again, and he came back, and we had coffee with Dr. Webster and Dr. Steve Robinson at the regional, and they're really proud of how well he's doing, and I am as well. And so where is Albert now? And these pictures didn't turn out as great as I had hoped, but Albert is, he stopped using substances in 2016. he stopped injecting substances in 2017 because he was still trying to recover the use of his legs. And he went on the street and he injected, and he felt like it was happening to him again. And so he decided that if he wanted to continue to play music, he needed to change his lifestyle. And so he gave up injecting drugs at that time. And then later on, he sought out treatments for hepatitis C because he was actively symptomatic. And so for those treatments, he had to give up alcohol. And once he gave up alcohol, his goal was to, give up alcohol for a year and then get the treatments for the hepatitis C. But he ended up not going back to alcohol even after the year was up because he felt so much better, without alcohol. And then, because he felt like he was on a roll, he also quit smoking, and now he's dedicated more to his wellness. And he still uses some substances, but maybe some of the less harmful, or what are perceived as the less harmful substances, such as cannabis and psychedelics. And so you can't really see in this picture, but he's wearing a Mom Stop the Harm t-shirt, and this is his car, which he has a Yukon license plate, but he's actually living in Quebec now. He just moved back from the Yukon, and he's got a Mom Stop the Harm bumper sticker. So he is one of my biggest supporters, one of my biggest fans, and the feeling is mutual. I think the world of him, and he's the one who started me on this path, and I'm so happy to be here. And so this is my last slide. So as I mentioned before, I am a co-facilitator of a peer-led support group called Holding Hope. And we provide support for families who have loved ones who are struggling, and they don't know where to turn because of the stigma. So their friends aren't supportive, their family's not supportive, and they don't know what to do. And what we provide for them that's different from other groups is that we educate them on non-stigmatizing language, and that abstinence isn't only the only goal, and that recovery isn't always people's goal, and that some people use substances because they like to, not just because they have a medical condition, and so it's important for families to know all of this, and to get support, because it's not easy. So I included the Holding Hope Nova Scotia email as well. We have a group in Nova Scotia, and so if you know of someone who's struggling, please feel free to send them our way. And then I've included links to our websites. We also have Healing Hearts groups, which are for people who have lost someone, and we don't have any in the Maritimes right now, but there are Canadian groups that you can join. And then our social media handles. And that's it.
That was amazing, Emily. Thanks, from all of us at SUNAR and beyond, for sharing that. I think Colton's going to take over the Q&As here in a minute, but sincerely, thanks for sharing such empathetic and vulnerable information. It's a lot of people at home, so thank you.
Thank you.
Yeah, thank you so much, Emily. That was very knowledgeable, and of course, your perspective is very unique as well. We do have a question in the Q&A. You kind of touched on it earlier. If you want to touch on it again, or
and that was that related to the substance use disorder?
Yes.
Term? Okay. So what? I guess I'll put that question back to the group. What should I say? Katie, would you like to answer that for me?
Sorry, Emily, to be answering Q&As during your presentation. But yeah, if I could, I wanted to speak to that. Yeah, so I think for me, and I think everybody's different, but I do have lived experience of IV drug use, and substance use disorder pathologizes substance use, and that's why I don't like it. It also perpetuates the brain disease model. So the brain disease model suggests that addiction is progressive. It always gets worse. And it leaves out things like trauma and other factors in a person's life. And like my experience of substance use wasn't, you know, increasingly worse over time. It got better when I got tools to deal with my life and coping skills. And I think in general, at least for myself, I feel like we're over medicalized, and not to say there isn't a place for, you know, I've sought medical support around my substance use in the past, but I think it'd be really great if we could go into our doctor and talk about our substance use health. Like, hey, I think, you know, maybe I want to cut back, or I want to use in a different way. But instead, I think the problem is then the doctor wants to diagnose you with like a problem. And the reasons you covered around stigma, then, you know, we're fearful that we wouldn't be given medications that are controlled substances if we disclose that kind of thing. But I think it would be amazing if I could imagine a future where we could discuss our substance use health with our doctor. So for me personally, like some people really like, you know, having that term fits for them. But I think it's a good conversation to have for sure. But I think substance use fits though in most cases. But I think it's important that people should be able to describe their own experiences in the way that works for them. Yeah, and I guess I worry too, if we use that term for others, that we're diagnosing other people as well. So I try to shy away from it. But it's like you said, it's a very used term, and so we've gotten pretty familiar with it. But those are my 2 cents on it. Thanks.
Thank you for that insight. Did anyone else have any questions or comments?
Yeah, we do have a comment from Laura Chapman, and they say, "Thank you, Emily, for sharing and teaching. I have no question. I just want to express my gratitude."
Thank you, Laura.
Last time I was on the front line seeking help, like with a condition, I was wearing my Nice People Use Drugs shirt, and the frontline healthcare worker said, "You're not one of those people, are you?" So I just want to say thanks for being like an awesome person in harm reduction on the other side of the lines, because that was pretty shitty. And your presentation, like if you keep on running into those things over and over, and you're stigmatized for your prescription, your use, and then also you just over and over, it takes away your voice, right? So with SUNAR's help and help from people like you and people like within these industries that get it, I've actually started like speaking for the healthcare I need and the tools I need. And it's the first time, and that pain didn't need to happen the same way. So like, I really, really congratulate you for sharing the vulnerable stories you do. And yeah, I'm going through some similar stuff. So thanks a lot.
Thank you for that. And you know, my contact information was in my last slide, and I don't know if it's in my if it was in the any of the information that SUNAR is sending out, but if anybody has any similar experience or different experience or anything that they want to share with me, because I do give this presentation to other healthcare workers, and I do have upcoming plans to deliver it to others. And so all of those interactions with the healthcare system, you know, having those stories really gives it an additional impact. So I would love to hear if you know, if anybody has things that they want to share with me.
No more questions coming in, Colton?
No, I don't see any questions, but Emily, I actually have a question if you don't mind.
Sure.
You did talk about your son's experience and how him seeking medical attention, he was deemed as drug seeking. Do you have any advice as someone with a healthcare background on how a patient who is deemed as drug seeking can help advocate for themselves or be taken more seriously?
I don't actually. I don't, because my son ended up, he went to an emergency room in Hamilton, Ontario, after he after he left St. John, and he was still recovering from the surgery and everything. And he told them what happened to him. He said, my arms are tingling, my legs are tingling, and I just had this abscess and I need an MRI because there's something, I think there's something still there. And they said, no, you're looking for drugs and go away. And so he said, well, I need you to call my mom because she knows and she can tell you what happened. And they wouldn't call me. And so I would never recommend that somebody do this because I'm a healthcare worker, but he actually lit a joint in the emergency room, and that really got their attention. And then they were going to throw him out, and he said, I'm not going anywhere until you call my mom. And so the hospital administrator was called in. It was 8 o'clock at night, and she called me, and I told them, I told her what he had just been through, and that what he was saying was true. And she said, okay, we'll admit him, we'll do an MRI. And so he needed that from me, and he wouldn't, otherwise they wouldn't have listened to him. And so I wish I had an answer for you for that, but I don't. But again, if anybody on the call has advice or suggestions, I would absolutely love to hear it.
Thank you, Emily. And yeah, as someone with lived experience myself, it's difficult, even, years later going and seeking help. That's still on your record and type thing. And yeah, there are definitely some stigma and biases still in the healthcare industry, unfortunately.
Definitely.
We just had another question come in. This is from Kate Lambert, and they ask, do you have any insight on how to engage healthcare workers in these types of presentations? Sometimes it feels like we're, quote, preaching to the choir, which is great to see familiar faces, but it's so important to broaden our reach.
Yeah. And I think my only suggestion there is to, for you as the choir, to advocate to your coworkers and say, listen, and just start broadening your circle and tell people, I just watched this presentation, or I just spoke to somebody, and take every opportunity that you can to educate and spread the word to people, because you're right. We're a group of people who are passionate about this. And so we're sharing information back and forth, but how do we reach a broader group? You're absolutely right. I am speaking to, because I have a pharmacist on my toxicology network, I'm speaking to a group of pharmacists in September, which I'm really excited about. And so broadening that reach as much as we can is what's going to change people.
Thank you, Emily. And also thank you, Steve and Sam in the chat. Steve said, take a peer health navigator. Sam also mentioned that as well. And she also says, as experience as an ER nurse, I always advocate for patients to bring in an advocate. And they echoed what Steve said about the peer health navigator, but also added there might be one available for Indigenous health navigators for patients who identify as Indigenous.
That's perfect. Thank you.
Okay, I have another question come in from Kelsey McDonald. They say, I've struggled with so much stigma by asking for no opioids when I'm getting a prescription. It's like they've become standard to prescribe that I'm a burden for asking for another form of pain relief that does not involve opioids. It's frustrating. And they added, thank you for this training. It's been great to hear your stories and insights.
Thank you. So there's a message in the chat from Jessica, and she says, stand your ground. That's her advice, and that's great advice. And that's what Albert did. Arguably, he stood his ground and said, I'm not leaving. And if you're there alone, especially these days where we don't always let people have someone in with them, because of the pandemic restrictions. So that's really good advice. Thank you I just want to say thank you to all of the kind messages in the chat. That's really nice. I'm really grateful to have the opportunity to share with you guys. And, speaking about my story has reduced the amount of shame that I experienced in the beginning. And, Albert never had any shame from the beginning, and which is fabulous. And I learned a lot from him that way. And so he's always happy and supportive of me sharing his story.
Emily, I really liked how organic your presentation was and showed how many connective pieces there are, because that doctor who had a stigma against cannabis doesn't understand that if I don't have that RX at the dosage I need, then other things happen in my life. And that's like a choice thing, right? And that choice is at the end of his pen with privilege. And the stigmatizing words and the way they made me feel in that room was unbelievable. And I had to call their secretary to even get them to open up the avenue to talk again to my cannabis advocate. And now I have a bigger prescription than I ever had before, which is ridiculous, but there we go. So like sincerely, like the whole connective part of your presentation is really beautiful, because it's like a community of care and health together.
Thank you, Steve. And I'm really sorry that happened to you. And this is why we do this. This is why we advocate. And because we need to change some of the stigma that's very much present in the healthcare system. Thank you.
Yeah. And I just want to take this moment also just to thank everyone for showing up and the kind words they've shared with Emily. And I totally agree with Emily, like just sharing these stories and being in commune with each other is exactly how we deal with the chaos that policies that don't work for us and colonialism have created. So like legitimately thank you for everyone coming and being in the space, and thank you for an amazing presentation.
Thanks everyone for coming.